Okay, as everybody starts to enter this room, we're gonna get going so we can stay within the 1 hour time frame. So welcome everybody. This is our first seminar in this seminar series. It's our second time doing this virtually. And this time around, we've tried to take into consideration a lot of the comments we received from all of you. And so you'll notice, for those of you that attended last year, that a lot of our topics are based on the questions and comments we received in the survey that we send after each seminar. So I'm very, very happy to introduce Dr. Stephen Narod, who many of you may know. He's a Canadian clinician scientist who directs the Familial Breast Cancer Clinic here in Toronto at the Women's College Hospital. He's a professor at the Dalla Lana School of Public Health at the University of Toronto and a senior scientist at the Women's College Research Institute. He has led the Familial Breast Cancer Research Unit for the past 25 years and has established the largest international study of BRCA mutation carriers that currently has over 17,000 women enrolled. Dr. Narod has shaped our current knowledge of how to assess breast and ovarian cancer risk and how to reduce cancer mortality among carriers of a BRCA1 or 2 mutation. And this includes the impact of screening, prevention, and treatment. With more than, right now it says 900, but we've reached 1,000 publications to date. Dr. Narod is one of the most influential cancer researchers in the world. And so today he is going to be talking about managing cancer risk among mutation carriers after age 50. Just to remind everybody, please put your comments and questions in the comment box. And then at the end of the presentation, Dr. Metcalf and I will navigate some of the most common topics. Dr. Narod, go ahead.
Yes, good afternoon, everybody, and thanks for joining us again at Women's College Hospital for our virtual hereditary cancer series. And you might ask why over 50. So I guess we thought a lot of the questions and a lot of the audience, I'm not sure how many are over 50, but it's an interesting age because you sort of transition from that age of before menopause to after menopause. And I think you really lots of one is not out of the woods at age 50 in terms of these genes. So we think of the whole life course in the women, really from 18 to probably age 100, if we're optimistic. But for the sake of research, we generally follow the women till about age 75. Women under 40 have different concerns than women over 50. Women under 40 will, of course, be focusing on family things and having babies, fertility, storing eggs, etc., and will also be premenopausal. Now, not all women reach menopause by age 50, but that's about the average. And it's easier to classify women by age than by their menopausal status. So we chose to sort of ask the question, once I reach age 50, and I'm hoping for a long life, not influenced by cancer, from my age 50 on, how do I go about it? What are the questions I ask? What are the numbers I have to think? What should I ask my doctor? What should we ask the researchers? And how can we do our utmost to lead a long, normal, healthy, and cancer-free life? So here we've actually started with women age 50. This, of course, is a long tradition of research done at Women's College Hospital, just so to see that much of this is based on those 17,000 women that Dr. Katsopoulos talked about, which is an increasing, starting from 1995. And that's kind of interesting. That's another number. We talked about 50, now we talk about 25 years. Now, it's interesting, since I moved here in 1995, was just about the time we started doing genetic testing in North America for BRCA1 and BRCA2 mutations. And it became increasingly available in Canada, Ontario, and North America. And you can see in our studies, we've accumulated women over the past 25 years and continue to do so, women with mutations, and we follow them and ask them questions. So now we're up to about 17,000. And it's timely to say, so how far have we come since 1995 in our ability to help these women? And what do we really want to measure? We want to measure what our goals are: preventing cancer, preventing death from cancer. Primarily breast cancer, ovarian cancer, but there are other cancers. Now, today I'm going to talk about preventing cancer. Maybe for another talk, we talk about preventing death from cancer. Might seem a little contradictory, but in a sense, certain things are used for preventing cancer, like surgery, chemoprevention. Other things we can't emphasize enough are there for preventing death. For example, screening, we all know about MRI screening, is not going to prevent you from getting cancer, but the hope is it will prevent you from dying of cancer. And that is certainly an ongoing study of ours. One of our largest studies is asking the question, can I achieve a similar outcome with preventive surgery as I can with annual MRI screening? Now, to ask that question, we're asking about dying of breast cancer. Of course, MRI screening is not going to prevent cancer. It'll just prevent the hope that we'll diagnose those cancers early, when the great majority of women will survive their cancers. And hopefully many of them will be able to found small enough so that they can have a lumpectomy, perhaps, avoid extensive surgery, and ideally it's small enough to avoid chemotherapy. So where do all these patients come from? Well, these are kind of the highlighted countries around the world. Canada, United States, Bahamas, Norway, Poland, Austria, Italy, Spain, Portugal, and Israel are the main contributors over the past 25 years. I'm not going to, in this talk, I'm going to put them all together in our study. Having said that, it is of course interesting and profound and important that the rates of uptake of the various preventive things, surgery, MRI, vary considerably from country to country. In particular, Canada and the United States are much more likely to initiate preventive surgery programs than are in those other countries. The exception is Netherlands is very active in cancer preventive surgery. However, they're not one of our participating centers. So I'm going to ask a few basic questions to give you some basic background information, but I'm focusing on women over 50. So let's say for the sake of the discussion, I'm following these women from age 50 to age 75. And I'm asking the question, if I don't have cancer at age 50 and I have a mutation, what's my chance of getting it by the time I hit 75? I could have done 80, but we're starting to lose information over 80. And one would say 75, I think, is a reasonable cutoff. Although I'm not to say that after 75, no one should worry about cancer or, think about screening, but it's something that's a matter of discussion. So let's start. What's the risk of breast cancer in BRCA1 carriers between age 50 and 75? Now, this was based on our large study. I'm not going to go into details of the methods of the calculations. I don't think it's, I believe that we've done it the right way and that these represent accurate estimates. So this is first, if I don't have surgery, what's the chance of me getting breast cancer if I have a BRCA1 mutation between 50 and 75? And it's 41%, which is less than the lifetime risk, which we usually quote from age 25 to age 75, around 70%. But you can see more than half of the risk of breast cancer entails over age 50 to 75. So that's a substantial risk. And it certainly means at age 50, we don't want to be saying, well, you've outlived the period of risk. Same thing for BRCA2 carriers. What's the risk of getting breast cancer, assuming I don't have breast cancer at 50, but between 50 and 75? And the risk is almost the same. These risks show adding cumulative risk between 50 and 75 ends up at around 45%. But you can sort of look at the curve and see it roughly equal over from age 50 to 75. So certainly, we're not comfortable sitting back and saying, well, that risk is low enough that we can feel comfortable by just going for regular mammogram screening. We want to do something more, whether that's surgery, chemoprevention, or MRI is the question. And now let's talk about ovarian cancer, the other big outcome we're concerned about in BRCA1. My chance of getting ovarian cancer from age 50 to 75 is 30%. Well, we all agree, I think those of us on our team would all agree 30% is not acceptable. So at age 50, we would recommend having a preventive surgery, removal of the ovaries, something we do here at Women's College Hospital. Now, it's sort of easy for me to make that recommendation because it's effective. The operation can be done as an outpatient, go home the same day. And there's no real alternative to surgery for screening. The other thing is at age 50, you won't run into issues regarding fertility. Most women don't say, look, doc, I don't want to have my ovaries out at 50 because I want to have more kids. And mostly also the issue of menopause. There's a larger impact on preventing ovarectomy at an age 40-year-old who hasn't gone through menopause than someone who has. And even those women at age 50 who haven't gone through menopause, we would encourage them to have the operation and undergo a little earlier menopause than wait and take the chance of getting ovarian cancer. But let's even look at age 60. So from age 60 to age 75, the chance of getting ovarian cancer is 11%. So is that high enough for me to recommend a 60-year-old woman to have her ovaries removed? I would say it's a question of discussion for the doctors, for the gynecologists, for me, but I would say I think so. Certainly there will be women who have medical conditions, one or another, who may not be eligible because of a medical condition. But in terms of cancer risk, I do think it's reasonable to do 10 ovarectomies to prevent one ovarian cancer. What about for BRCA2 ovarian cancer? It's also 20%. So we would have little hesitation here at Women's College Hospital in recommending an ovarectomy, removal of the ovaries for 50-year-old women to prevent a 19% chance of getting ovarian cancer, 1 in 5. We'll be happy to do 5 ovarectomies to prevent 1 ovarian cancer. What about 60? Well, there it's even higher. So BRCA2 ovarian cancers tend to be a little later onset. I think at age 60, undergoing health, I would do it. But notice by age 65, the risk seems to dissipate. So these are questions that, we have ongoing things. Urge people to be aware of the numbers, discuss with their gynecologists, etc. Okay, so let's talk about reducing the risk of ovarian cancer. We know that oral contraceptives reduce the risk of ovarian cancer. Do we recommend that for women after age 50? Well, we don't have any data. It's a simple but interesting question. I don't know anybody that started oral contraceptives after age 50 to prevent cancer, so we really don't know. I haven't yet been recommending those to healthy women over age 50. Breastfeeding reduces ovarian cancer, but that's something for younger women. Tubal ligation reduces ovarian cancer, but I don't think it's a substitute for ovarectomy. Really, preventive bilateral salpingo ovarectomy, removal of the ovaries and the tubes, will reduce the risk of ovarian fallopian cancer by 87%. So that's our gold standard. We did a study earlier this year, or a couple of years ago now, in Poland, where we compared women who had an ovarectomy to those that went for screening, ultrasound screening, and you could see on the left-hand side, although it's scrunched up, the blue line, they were more likely to get ovarian cancer if they went for screening than if they went for surgery. But moreover, of the women, the 73 subjects who were identified through screening, 27 died, and we estimate that the majority of them will die within 5 years or 6 or 7 years of detection. So no screening. We're not going to recommend a screening procedure where if we find cancer through screening, you're probably going to die anyway. So, I mean, that's why we're pretty much focused on preventive surgery. I should say, so this is for ovary screening. We are in the process of doing a similar analysis for breast cancer screening versus surgery. Hope to have that out by the end of the year. So if we reduce, now talking about reducing the risk of breast cancer, that's where we're focused on. We know that surgery reduces the risk by 95%. If you don't have breast cancer, when we remove your breast for surgical prevention, the chances of getting breast cancer goes down by 95%. There was some controversy on the benefit of oophorectomy. Does taking out your ovaries reduce the risk of breast cancer? I think as far as we're concerned, we find no evidence that that's true. Tamoxifen is a chemopreventive drug given to prevent ovarian breast cancer. I don't know if it's effective or not. The problem is so few women are comfortable taking it that we haven't been able to accumulate the right numbers. MRI, on the other hand, 75% of the women in the study have had an MRI. We really don't have enough evidence to say that it prevents death from breast cancer, to be determined as well. So the mastectomy, our big question here at Women's College Hospital, what's the relative benefits of bilateral mastectomy versus MRI screening every year in preventing death? If they were equal, one could argue that a woman may be willing to keep her breasts and go for the MRI screening, but that's probably our most important question we're facing. Tamoxifen, like I said, this is 25 years of work. And 50 of the women over 50 took tamoxifen before. It's a very small number. We do see a much reduced risk of breast cancer with tamoxifen, but the numbers are really too small to make any conclusions. So that's an ongoing struggle. Screening with MRI, I want to put in some good word for it. In Ontario, we had, now this is really interesting, and it's up to the patient and everybody to ask themselves what this means. So this was a study we did with Ellen Warner and others at Women's College Hospital. No, at Sunnybrook and Women's. And we took 496 women, did MRIs on them every year. And those 496, 57 got cancer, breast cancer. 49 of those cancers were found by the MRI. And out of the 496 women, so far, 4 died of breast cancer. So the number of deaths, I think, is pretty small. I mean, that was an encouraging sign. 4 out of 496 died. And that's good. I mean, I think it's not good that they died, but the numbers are probably acceptable. But, 57 of them got breast cancer over the 5 years. And those were treated with chemotherapy largely. So, I mean, one can prevent death, but certainly there were 53 other women who didn't die who were diagnosed and treated for breast cancer. So I think it's a lot of it, we want to clarify this, but much of that would be up to the women to decide in her course. Enough said about MRI. So now we're going to talk about women over 50 in our study. There was about 2,000 women in our study that had a BRCA1 or BRCA2 mutation that were healthy at age 50, had no cancer before age 50. Now, what I'm doing here is I'm just showing you everything about all these women. Some of these women had an MRI, 75%. Some of them, 46% had an oophorectomy. And 15% had bilateral mastectomy. So I included everybody that we followed. These 2,000 women, 1,400 BRCA1, 700 BRCA2. Notice only about 60 of them had taken tamoxifen. About 46% of the BRCA1 had an oophorectomy by the time when we started the study. 33 had taken hormone replacement therapy, and 14% of BRCA1, small number, but remember this is an international study. The number would be higher in Canada. Okay, you can see where they came from: Canada, Poland, United States and other countries. I showed you Austria, Italy, Israel. Coming ahead, of those women, 200, I followed them forward, not everybody till 68, 75, but they were followed for an average, I think, 8 or 9 years. We saw 379 of them got cancer. So these were patients, these were women who had a BRCA1 and a BRCA2 mutation, and they knew they had a mutation, and their doctors knew they had a mutation, and they made up their minds before age 50 whether or not to have the mastectomy or the oophorectomy or to take these medications. They had chosen the course, and 379 of them got cancer. Is that too many? Well, let's look at that. What kind of cancers did they get? These 379 cancers. 232 are breast cancers, 45 are ovarian cancers, 12 are endometrial or uterus cancers, 12 are fallopian cancers, and cervix cancers 1 and lung cancer 9. So I stuck those ones first. Why did I put lung cancer? 8 of the 9 were smokers. But if we look at the breast, ovary, uterus, fallopian, and cervix, I'm highlighting those because those are the ones that are preventable. Those are the ones, breast, ovary, uterus, fallopian tube, and cervix, which we are trying to prevent. And that was 80% of them. If we look at the residual cancers, the other cancers, peritoneal, melanoma, colon, pancreas, lymphoma, bladder, thyroid, salivary gland, sarcomas, leukemias, and lymphomas, those cancers are not, two things about them, with the exception of peritoneal cancer, they're not really caused by the genes. Those are the background rates of cancer, and they're not preventable. But what's preventable is 80% of them was breast, ovary, uterus, fallopian tube, cervix. But what do I mean by preventable? I mean, I hate to break it. I meant preventable by surgery. We don't have another way currently of achieving that prevention without undergoing the surgery. But it was a little, a matter of question, a matter of debate, a matter of interest. How was it that 379 of these women, after knowing they had a mutation and discussing it with their doctor, 379 got cancer, of which 80% might have been prevented? So let's just look at it in more detail. 50, okay, these are the women. Now I'm including everybody. BRCA1 carriers, all cancers, 53% got cancer between 50 and 75, despite taking measures to prevent it and knowing that a mutation. 51% of the BRCA2 carriers got cancer in that 25-year period between 50 and 75. I would argue that that's too high. Well, I would argue that, but is that better than what would we see if they didn't know they had a mutation? Yeah. So what is this? This is the penetrance. This is the women who didn't have any preventive measure, which we can sort of take as a proxy or a surrogate for what would be the risk. This is the risk of cancer, the BRCA1 or BRCA2 carrier from age 50 to 75 who doesn't know they had a mutation. So by telling the woman you got a mutation and giving her all the options, we will drop that from 80% to 50%. Okay, so these are women who knew, these are women who don't know. It's something. I mean, 50 is a lot better than 80. But are we there yet? Who are these people? These are the women who had both a mastectomy and an oophorectomy before age 50. Only 9% got cancer. So if a woman had neither, they had 80% chance. The women had both, they had 9% chance. Well, you could argue, yes, but MRI might be equally effective, et cetera. You didn't count the deaths, you just counted the number of cancers. Fine, it's a matter of discussion. I hope we have some of that discussion today in the question and answer period. But if you look at the cancers that they got, we don't have the slide here. There were only a couple of breast cancers. The majority of those cancers were the cancers that we saw in the general population, and things that we're not in a position to prevent: lymphoma, bladder, thyroid, parotid. Now, pancreas cancer is something people are concerned about. There is an increased risk, but let's just put these risks into perspective. Let us put these risks into perspective. Of the 379 cancers, breast was 232, ovary was 45, uterus was 12, fallopian tube was 12. If I can prevent those, I will think I have done a good job. I'd like to prevent the pancreas, etc. But if there's any weakness in our system and in our paradigm and in our structure, it's not because we haven't been able to prevent pancreatic cancer. It's because even though we're able to prevent breast and ovarian cancer, we, for one reason or another, have not been enabled to do so. Now, I'm not saying it's not the women's choice. I'm not saying some women may wish to proceed with screening versus surgery. I'm just saying in the facts of my study, and you're welcome to interpret them as you wish, is that those women who had neither surgery, 80% got cancer, and of those who had both surgeries, 9% cancer. Well, how does that compare to the general population of people without a mutation? In fact, that's 21%, which kind of blew me away. Of the people without a mutation, we reckon in Ontario between age 50 and 75, 21%, 1 in 5 women will get cancer between the age of 50 and 75. Of a woman with this predisposing mutation, it's down to 9% having the surgery. And that's actually not that surprising, because in the general population, the most common cancers are the same ones I just showed you. In the general population of women living in Ontario, the main causes of cancer are breast, ovary, uterus, cervix, lung, and colon. Right? Breast, ovary, cervix, lung, and colon are the main cancers. Well, thyroid, I could include. And most of those are the cancers we see in women with BRCA1. So the overlap is considerable. Food for thought. Anyways, finishing up, I just wanted to say our other project, just so people remind you, is we've been pushing forward the SCREEN project, the idea being to offer genetic testing to everybody. I'm not saying everybody necessarily needs it or et cetera, but we did think that if some women wish to have this information about whether they carried a mutation or not, we didn't really think it was fair play to deny them the opportunity to have the test and have the knowledge because they didn't qualify by the government's regulations. Well, we all know the government likes to make regulations. Not many of them, most of them are about COVID. And I'm not saying they're right or wrong. I'm just saying it for some things like genetic testing, I think, we should be making it one of our goals to let it available to women who wish to have it. So we created that here at Women's College Hospital, the SCREEN project, to bring genetic testing to all men and women. It's a partnership with our lab in Invitae. It does cost money. The cost is $250, but it's available to everybody. And that's sort of the way that the Canadian system works. If it were to be without cost on the healthcare system, you can be sure the politicians and the government would control the access to the testing. But as long as it's outside the healthcare system on a pay for patient basis, then there are no restrictions. And we've never had any issues with the Canadian Cancer Society or any provincial government about whether or not we should be offering testing to all Canadians based on a pay-per-service basis. So just concluding our sort of at this stage, and I think I got a lot of time for questions. I mean, we show that surgery is effective in reducing cancer risk. I mean, unfortunately, it is surgery, and there's lots that can be said about surgery, but I would like to emphasize that surgery after age 50 is a different animal than surgery before age 40, in particular for surgical prevention for bilateral surgical oophorectomy. However, I mean, even though we talked about over age 50, we want to be, in order to maximize the benefit of these surgical preventers, we would think preventive mastectomy would be something to consider from age 30, where the risk of breast cancer becomes substantial. In terms of preventing ovarian cancer, I kind of tried to show that for a woman at age 50 who has both ovaries intact and has a mutation, it would be wise to have her ovaries removed. But those aren't our recommendations. Our recommendations are age 35 for BRCA1, age 45 for BRCA2. Now, those recommendations are made purely on the basis of the risk of cancer. I didn't say 35 because it's not like people, those were the earliest cancers. And certainly the considerations for fertility and for surgical prevention, hormone replacement therapy, all have to be taken into consideration. But, and it's a big but, Joanne and others here have shown that you could do a surgery at age 35 and give hormone replacement therapy to help for the symptoms of menopause without increasing the risk of breast cancer. So that's a big plus. Having the ability to prescribe hormone replacement therapy to these women really aids in our decision to make an offer, because we can think that greatly improves the quality of life. I'm not saying it goes to perfect, but it's certainly helpful. Now, there's a lot of discussion about hysterectomy, which is having your uterus removed at the time of the oophorectomy, right? So generally we recommend both ovaries removed, both fallopian tubes removed, but we at Women's College Hospital generally don't offer hysterectomy at the same time for various reasons. Now, let's just look at that again, and I'm not here to make a complete judgment, but if I look at the cancers that were identified, 12 of them were endometrial cancers and one was cervical cancers. So that's 13 cancers that are prevented by the hysterectomy. 13 cancers, well, that's certainly not as many as the 45 ovarian cancers. But look at it like this. If I do a hysterectomy, if I do an oophorectomy without a hysterectomy, I will prevent 45 the ovary and the fallopian. I'll prevent 57. If I do the hysterectomy, I'll prevent 67. Yeah, I mean, there's something to be said for that, but it's a matter of discussion between each woman and their doctor. I'm just giving the facts. So at that point, we talk about the conclusions. Essentially, I'm not insisting that every doctor follows my rules. I'm not insisting that every patient, is optimally a patient for surgery. I'm saying that in general, I think to simplify the way we would look at risk reduction for breast and ovarian cancer in women in 2020, 25 years in the game, that this is what we've got. I wish we had more, but here we are in 2020. We have an effective way. I can take you from 80% risk to 9% risk. But if you want, that's, to do so, I have to consider both preventive mastectomy and oophorectomy. And lots of people contributed all through the world, and hopefully many will continue to do so. Some have been involved with me for this for 25 years. Carl Moeller in Norway stands out. The Polish people have been a huge help with us. We've been running with them for 20 years. They've contributed thousands of patients. Anyways, if I stirred some controversy, I'm not going to avoid having any questions or discussions, and look forward to your comments. And
thanks so much, Dr. Narod. And I think it's so interesting. And often we don't see these numbers presented by age of a woman, and maybe we need to be thinking about the age of a woman. Can you just put it into perspective for us in terms of what would be the average 50 to 70-year-old? What would be the cumulative risk of her developing any type of cancer, even if she wasn't a BRCA1 or 2?
21%.
So we're talking about the average woman having 21%, and by having a prophylactic mastectomy and oophorectomy, she's down at 9%. So considerably lower.
Well, the average women, we don't do the recommendation, right, Kelly? So the average
No, but I'm just saying we are bringing by these two procedures, we can bring the risk down to lower than the average.
For these two procedures, I can take the risk of a woman who carries a mutation below that of average woman sitting on the bus next to her.
Exactly. Okay, so I think it's good to put those numbers into perspective for people. So let's open it up to questions. And I see some people have put it in the chat, and I'm sorry, that was our error. We should have turned that off because it's really hard to monitor chat and Q&A. So if you did have a question in the chat, can you please re-enter it into the Q&A for us? And Dr. Katsopoulos and I will monitor that.
We can look at the chat, I guess.
Okay, so Dr. Narod, can you talk about the effect of hormone replacement therapy on breast cancer risk after having your ovaries removed at the age of 43? What are the statistics? What are the recommendations?
Well, we did, I think John gave that, but to review, so we looked at our patients. So some get hormone replacement therapy at 43, assuming that's surgically induced menopause, but there are many women in their 50s who went through natural menopause or who had surgery and didn't go through menopause. Our basic feeling comfort zone is estrogen alone would be the best preparation. We see the risk of estrogen alone did not increase the risk of breast cancer. There's some evidence that estrogen and progesterone increased it. So we tend to recommend an estrogen alone preparation, both for women who induced surgical menopause and for women who had a natural menopause. And I should say, I don't think there's any contraindication or any reason why women shouldn't be given estrogen as a standalone hormone therapy after either surgical or natural menopause. Well, I'd say good, but the thing is, after breast cancer, we generally don't do it. Now, we don't do it based on studies in the general population. Some people in the general population will give estrogen to people with estrogen receptor negative breast cancer. Our general recommendation is if you had breast cancer, we don't give estrogen replacement therapy or androgen therapy. Having said that, there's a couple hundred women in our study who did take it. I'm not sure they took it on their own volition or with doctor's advice. We will be looking at that. Tough study to do, but we're accumulating some data on women who took hormone therapy after breast cancer with these mutations.
Can I just add to that? When we talk about hormone replacement therapy after oophorectomy, when Dr. Narod's speaking about estrogen alone versus estrogen and progesterone, the decision really depends on whether or not you've had your uterus removed at the time of oophorectomy. So again, this is again getting to what Dr. Narod raised in his last slide on whether or not women should be removing their uterus at the time of oophorectomy, because that simplifies things so that you are a candidate for estrogen alone, HRT, without having a negative impact on your risk of breast cancer. So it's a little bit complicated. So women with a uterus are advised to take estrogen and progesterone, whereas women without a uterus can take estrogen alone, HRT.
Lots of questions, eh? Go ahead.
Yeah.
Okay, so there's a lot of questions about what to do after you've had all your prophylactic surgeries and what standard of care is. And there's a lot of different case scenarios. So women who have had a preventative mastectomy and oophorectomy, what sort of follow-up they should be doing. And I'm thinking this is a very tailored approach to follow-up, but Dr. Narod, your suggestions? Some are asking about—
I would suggest,
anything.
I don't think there's anything. I mean, so if you look at, like Kelly, go back. So if you got both of these surgeries done, your risk of cancer is less than that of the general population. So why would I consider you to be special of interest? I mean, on the basis of the 9% cancer risk in them versus 21% in the average woman, with the exception, so I don't think we need to screen for peritoneal cancer, for residual breast cancer. I wouldn't recommend any screening. The exception, of course, is pancreatic cancer. The carriers of BRCA1 and BRCA2 women will still be at increased risk of pancreatic cancer. The risk is low. Like there were 6 cases of a 379. I don't have a good enough recommendation to recommend it. If I did, I would. The other one is melanoma. We just looked at that. Your risk of melanoma if you have a mutation is about 3% lifetime. Slightly higher than the general population. Way less than 1% a year. Like, is it worth going to the dermatologist 25 times for a 3% chance of melanoma? I'm having that discussion with a dermatologist now. My gut feeling is no, but you can go if you see something. I mean, I would, but so for what I do especially, I would certainly look for moles. And if I had symptoms, I would speak to my doctor and say, listen, I have a BRCA and a BRCA mutation. I'd let them know that as part of your medical care. But I don't think I would recommend MRI screening, pancreatic screening, ovarian screening, say 125. The basic ones. I would say, yeah, go home. You should be fine. But it's really, it's comforting for me to be able to say to a woman, oh, well, we've done this. Yeah, I think it's time to go home and, rest assured. There are no guarantees in life, but I mean, you want to put the odds on your side.
But there is a small caveat. Dr. Narod's making an important point. We're prolonging your life by having these surgeries, but that doesn't mean you should ignore your health with respect to other aspects. And so when you talk about screening, there is follow-up with respect to young women having their ovaries out to ensure they're maintaining their bone density. And that does occur, that is happening.
That's a good point.
Specialized clinics. And taking HRT after oophorectomy will help maintain your bone health. So, and help maintain hopefully.
Yeah, that's a good point. The bone is probably something. So
it's important to
think. Talking about young one, I'm talking about over 50.
Oh, right, sorry.
Over 50, I mean, that's a good point. Over 50, we don't have as many concerns about estrogen withdrawal. Whether or not an oophorectomy after the age of 50 has any influence on your bone health, I don't know. So if you had it, I'd probably follow the general recommendations, but certainly for surgical menopause, you should get your bones checked every couple of years.
Okay, I have another question for you, Dr. Narod, and it's really about the importance of not only knowing if you have a BRCA1 or 2 mutation, but also being aware of the ages of onset of cancers within your family. And we know the general recommendation for when a woman should have an oophorectomy, whether she's BRCA1 or BRCA2. But what if a woman has a sister who's had ovarian cancer at the age of 35? She's a BRCA2 carrier. So normally we wouldn't be recommending an oophorectomy till at least the age of 40. What would you suggest that she does? Should she be considering the
Well,
age?
I mean, there are always these exceptions. If you had a sister with an ovarian cancer at 35 and a BRCA2 mutation, I would do it at 35. But I mean, these numbers we see are based on thousands of women, and I think I want to avoid the temptation to overinterpret personalized risk. We lump all the women together.
Mm-hmm.
We lumped everybody together, those that didn't do it at an 80% risk and those who did it at a 9% risk. I mean, I'm not going to go from one category to the other based on family history, position, mutation, or whatever people are. You're either in one or the other. There are certainly, and now the other thing is I'm trying to say is this is a talk for about over 50. The issues of under 50 are much more complicated.
Yeah.
We could spend the whole time talking about 35-year-olds.
Mm-hmm.
That's the gray zone. We know that's the gray zone. We know that there are tons of issues.
Mm-hmm.
I would like to focus on the women in 50 because nobody ever said you should wait till after 50 to get the oophorectomy. I don't care what your family history is. So you can have nobody relative. You get it at 50. So we can spend the next 40 questions debating about 33-year-olds, but I would kind of like, that could be maybe a topic for another discussion. Early onset surgical.
So there's a really interesting question from someone in the UK who had a diagnosis of DCIS at age 40. She has a BRCA. I know it's a little bit personal, but it's interesting. She's asking about whether or not she should be advised to undergo an oophorectomy.
Excuse me?
BRCA1 mutation carrier with DCIS and had a mastectomy.
But she's 40.
She's 40.
And the question is, should you have a mastectomy or an
oophorectomy?
Well, I think whether or not you have DCIS, we recommend oophorectomy to BRCA1 carriers at 40. I don't think the DC, I don't want to, it's again, overcomplicating it. If she has a BRCA1 mutation and is age 40, I recommend a oophorectomy regardless of the history of DCIS.
Okay, thank you. There's a.
I'm
Any
just
other-
looking through the questions here.
Screening for other, no, there's no effective screening yet for ovarian cancer, pancreatic
There's a
cancer.
question about accessing genetic testing. And again, it's worth going to your primary care provider to see if you're eligible in whichever province you live in, if you're in Canada. And if you're not, Dr. Narod did mention the Screen Project. So that is accessible to any Canadian over the age of 18, men, women. So if you don't meet the criteria in your province and you want to have the testing, you can access that through the Screen Project. So just go onto your computer and look up the Screen Project and you'll find the link for that. There's a lot of questions about hot flashes and antidepressants and managing your menopausal symptoms. And I think if you're really interested in that, we had a great talk last year. And all of those talks that we did last year are posted on our website. So listen to the 1 hour talk. I think you'll get some great recommendations about how to manage some of those symptoms that you may be experiencing, may or may not everybody does.
And those can be dealt with by your gynecologist or family doctor, because that is a very personal question, and what works for one person may not work for another. What about recurrence? Do we want to get into breast cancer recurrence and mastectomy after? I know you've talked about it already in the presentation. There's quite a few people talking about having had a breast cancer diagnosis, for example, at age 60, whether or not they should return for mastectomy.
Those are best discussed individually. You know, what are the treatments of recurrent breast cancer? I mean, it depends on what we're talking about: local invasive recurrence, distant recurrence, recurrence after DCIS. We're talking about surgery, chemotherapy, oophorectomy. That's the whole topic. I mean, I'm not dismissing it, but I'm saying it would be kind of hard to make a general comment about that.
Quite a few questions about other cancers. I don't know if we want to go back to the list of cancers in our list that you showed. Colon and lung cancer, BRCA mutation carrier with colon cancer, lung cancer.
Okay, we did get 9 lung cancers in the cohort. My understanding of that, okay, that's kind of interesting. Yeah, let's do it. Lung cancer is like the second most common cause of cancer in Canadian women, right? And BRCA1, it's really low. Now, I had twice as many BRCA1s as many BRCA2s, right? 1,400 and 700. 4 in BRCA1, 5 in BRCA2. Lung cancer is rare in BRCA1. So instead of being in the second place, it dropped to 1, 2, 3, 4, 5, 6, 7. I mean, 8 of those 9 smoked. There's not a whole lot of BRCA1 specific stuff there. The cancer wasn't caused by the gene. What was the other? Pancreas? Yeah, I mean, look, we had a 4-2 thing here on pancreas and an 8 and the only one. That's cool, actually. I never saw this before, Kelly.
Mm-hmm.
I don't know, melanoma. Yeah, this is actually exactly true. The only ones that are more likely in BRCA2 than BRCA1 are lung and melanoma. We actually saw that even though the numbers are tiny. We know that lung is more common, is rare in BRCA1, and melanoma, you get a 2 to 3-fold increase in BRCA2. So the only cancers, even though this was half as many women, this is half as many women, but you can see that it's driven, I mean, the melanomas and the lung are higher in the BRCA2s. Can I prevent melanoma? Hey, we just wrote that paper. I don't know. We're talking, how do you prevent melanoma? Avoid the sun? Is it worth it to avoid the sun? You know, I'm not going to preach about staying out of the sun. You can preach about it, guys, but Did any of them die? Oh, the other thing about melanoma, I should say, this is fascinating. It was twice as common in the States as in Canada.
Hmm.
Well, that's from well, I mean, guess what? They get more sunshine. But the risk of the melanoma was the only one that was driven by the country you lived in. The rest of them were.
That could also have to do with the sunbed regulations in Canada versus the US.
Oh, you think it's
That's a
sunbed?
whole other topic, yes. I know we have
Well,
strict.
maybe we should tell carriers don't go to sunbeds. That's something I've never said in my life.
Yeah.
25 years, I've never told anybody to avoid a sunbed. Maybe I should.
Dr. Nair, I think what's interesting though is the majority of these cancers, if we added another column that said the general population and looked at risks, they would be very similar.
Yeah, no, exactly.
So let's stress that although that we did observe these cancers, it's not unexpected because this is what we would observe in the general population.
This is 1,400 women, right?
Exactly. So
We only got 6 colon, we only got 6 pancreas, 4 lymphomas.
yeah.
I mean,
So
you're
we have
right.
to remember that as well.
I could have another column, but
So like if we had the Canadian cancer statistics, we would
Yeah.
have
It would be
you know,
very similar.
colon and
we
lung is common.
we can,
Mhm.
there are rare cancers, salivary gland. My cousin had that.
Okay. I think we're just about out of time. There was one more question about the screen project. No, nobody has to come into a hospital for that. We actually send you a saliva kit and you provide the saliva sample in your home and you send it back to the lab.
Yeah.
So it's you don't have to just live in Ontario and be able to walk through the doors of Women's College Hospital. It is true that a man can carry the mutation just as likely as a woman. I'm just quickly going through some of these. There's a question about ATM that will be a discussion for another talk that's coming up this year. So there are other genes that we need to be thinking about as well. And we do want to bring you all the latest information on that as well. So we will be doing that this year. So I'm going to wrap it up and I'm going to, first of all, thank Dr. Narod. I think it's always a pleasure for all of us to hear from him again and some of the interesting findings. Again, we wouldn't be able to present any of these findings without all of you contributing to this large study that Dr. Narod talked about. If you're not involved in the study, please contact us and we will get you enrolled. So you can also contribute data to some of these really important discoveries that we're making that are having an impact on women around the world who are able to use these research results. I also want to remind you that you will be receiving some type of survey to ask about your experience. What can we do to improve? What would you like to hear about? What did you like about these seminars? I think we find it just as enjoyable to bring you this research as you do to hear it. And I'll remind you that we are offering these seminars once a month. Our next seminar will be presented by Dr. Gina McQuaig, who is a genetic counselor at Princess Margaret Hospital, talking about something that's really interesting. And we're thinking about how to communicate your genetic test information with other family members. And we have a long way to go to ensure that family members are all made aware of a genetic mutation within a family. And she's going to talk about how to best do that to ensure that your relatives are aware of their risk as well.
And maybe in case for those that are interested, I know our genetic counseling team had previously made a video that's on the Women's College YouTube channel on how to communicate with your family about a mutation status. So that's also interesting to share with your family members.
So please go to our website. There's a lot of information there that you can access. We upload all of these seminar series. We have some educational information as well. So I encourage you to visit the website. So thank you to everyone for attending today, and we look forward to seeing you next month on Friday, February the 25th, again at the lunchtime, which hopefully works for most people. And if you'd like to share this, it has been recorded. It will be posted on the website. So if you'd like to share with any of your relatives or friends who may be interested, please do that as well.
And there was just one more question about registering. Yes, you must register for each of the seminars you want to attend, and then we send you the Eventbrite link.
Great.
Thank
right.
you, everybody. Thank you,
Thanks
Dr.
again,
Narod.
Dr. Narod. And
Bye.
we'll see everybody next month. Bye-bye.